What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. Dr. Zach Baker here of Rehab to Perform and R2P Academy. And I have with me Dr. Christian Huckfeldt of our sports residency. He is one of our two sports residents that is wrapping up our 2022-2023 cohort, which is the second cohort to go through our sports residency. And this will be Christian's final journal article and research review podcast with us. I'm sure he will join us in the future after he moves on to the next chapter of his career. But Christian, welcome to your final journal article review. Do you mind giving us a heads up of the article that you chose? And for this month, we had medical conditions was kind of the theme of the month for the sports residency.
Yeah, so the article I found was called Non-Steroidal Anti-Inflammatory Drug, or NSAID prescriptions, are associated with increased stress fracture diagnosis in the U.S. Army population.
Awesome. And this is a topic that's been discussed not only this year, but in the previous year at the cohort. And this was actually one of the in-services that Dr. Samantha Curbelo did for us. It was actually her final in-service, where she talked about the utilization of NSAIDs in the collegiate sports population, and really just trying to paint a picture of, are there any protocols? What are recommendations? What does a role that a physical therapist plays in the collegiate sports environment when athletes are coming in and out of the training room, either reporting that they're taking NSAIDs on their own or asking for them from the trainers? What does that look like? What should we do? Are we involved? What kind of information should we be providing? So I'm glad that you picked this one as well, because it gives us another topic to talk about in a different population in what looks to be a longer-term study, but with an actual specific focus of trying to see, is there any correlation between NSAID use and stress fracture diagnostics? So Christian, can you talk to us a little bit just about the background of the study, kind of the rationale, and then ultimately what objective were they trying to find?
Yeah, definitely. I mean, widespread use of NSAIDs are something that I think in an outpatient clinic like we're in, we see people who have been taking NSAIDs for any amount of time, but especially people who have taken them for long term. I think in the research it's pretty well documented of some potential GI issues, potential cardiac and renal issues associated with taking these prolonged NSAIDs. The article did a pretty good job in the background discussing that NSAID's relationship to bone formation, meaning that it potentially suppresses bone formation, has been demonstrated in the animal population and kind of provides some biological plausibility for the human population. However, there hasn't been any specific studies on humans yet. So there's really not entirely sure what the effect between NSAID prescription and stress fracture risk is in humans. But this study really aimed to kind of identify from a large population of Army individuals whether they potentially would be associated with increased risk of stress fracture.
Awesome. And we're talking about U.S. Army. Patient population there, and it looks like they were able to pull over 1 million people for this, right? About 1,260,168 people, and this took place between the years of 2002 to 2011. So we've got a decade's worth of information to go off of here. Can you talk to us a little bit, just going into further detail about the actual interventions or processes of this study?
Yeah, so the study was retrospective in nature, meaning all of this information already existed in a big database. The researchers obviously just came up with the design and then dove into the data that was there to potentially draw conclusions from there. But like you said, they looked at this big, large database called the Total Army History Health Outcomes Database, which really looks at all of the injuries for potential people who were active duty Army population over a 10-year span, which you alluded to was just about 1.3 million individuals. And what they did is, through the use of kind of searching for ICD-9 codes, they found the incidence of stress fracture in this population. Basically, how many individuals, what percentage of individuals have a stress fracture at some point. Additionally, then they dove a little deeper and looked at everyone who was prescribed NSAIDs from anywhere between 1 and 6 months. And then they kind of compared the two to see, were individuals who were prescribed NSAIDs 1 to 6 months prior, did they have a greater risk of having a stress fracture, or did they not have a greater risk? They also did this for kind of two populations. One was the entire Army population, which is kind of the big sample size. And then two, they also looked at individuals who had just undergone basic combat training, which to my understanding is about a 10-week, pretty intensive physical and mental challenging activity to really prepare individuals for active duty service. So they looked at whether the NSAIDs potentially caused or potentially were associated with greater risk of stress fracture, both in the entire population as well as the population of basic combat training as well.
Yeah, and I have no military background myself, but just with conversations from patients and just some of the literature I've seen, in that basic training, there is a high dropout rate for incidents for things such as stress fractures. And a lot of it has to do with such a high increase in workload and just the types of activities that they're doing. So I am glad that stress fracture was the thing that they selected for this article. Obviously, we're looking at a correlative study here in regards to NSAID utilization and prevalence of stress fractures or incidence of stress fractures. We'll talk a little bit later in regards to what are some other things that may kind of muddy the waters with this or may look into this. They talked about a list of covariates as well, things such as age, sex, race, ethnicity, education level, BMI, so on and so forth, that may be correlated into incidence levels as well. But can you dive into some of the results that were found within this study?
Yeah, so just briefly on the demographics, about 24,000 stress fractures were found. 60% of those were between individuals from 20 to 30 years old, which is kind of our prime patient population that we're talking about here. Of the 24,000 that were found, just about 2/3 of them were in the tibia fibula, about 20% were in the metatarsals, and just over 10% were at the femoral neck and femoral shaft. So I feel like that's pretty consistent with what we see, A, in the literature, and B, kind of what we've seen here clinically at Rehab to perform. Generally speaking, they're between the age group of 20 and 30 years old with lower body injuries typically, which makes sense with a lot of the impact that these individuals will have to go through. So when we look at the entire kind of Army population, when individuals who were prescribed NSAIDs were compared with controls who were not, those who were prescribed NSAIDs were associated with a 2.9 times increase in stress fracture risk, which I thought was pretty intense. Of the individuals who had a stress fracture, 41% of them had taken NSAIDs, whereas 19% of the controls who did not have a stress fracture took NSAIDs. So those numbers I thought were pretty serious too. When we dive a little deeper into the basic combat training group only, similarly, when compared with controls, there was a 5.3 times increase in stress fracture risk if you were prescribed NSAIDs. And then diving a little deeper as well, 20% of those who had a stress fracture took NSAIDs, whereas only 4% of the control group had taken NSAIDs.
So we got some numbers to work off of here. You know, what those numbers actually mean, we'll start to talk about now, but there are some numbers in here that you can't really ignore when you're talking about, you know, almost a threefold increase. 41% of stress fracture cases took NSAIDs. Those are numbers that you just can't ignore. But with this, can you talk a little bit about just what's your takeaway from that? And then are there any limitations or things that we should be mindful of so that we're not walking away from this article just thinking, oh, if you take NSAIDs, you're probably pretty likely you're going to have a stress fracture?
Sure. It's like anything. Everything is multifactorial. And in the stress fracture research and literature, there's a lot of stuff that's published out there about potential causative factors, primarily relating around relative energy deficiency in sport, or RED-S, if you're familiar with that. So I do just want to make the note that the prescription of NSAIDs, I think, is probably just one component of this. It's not the entire situation. But having said that, the research in this study is pretty profound in that there's a 2.9-fold increase in stress fracture risk associated with the full population if you were prescribed NSAIDs, whereas in the basic combat training only was a 5.3 times increase. So I think those numbers are pretty pretty tough to kind of ignore and move past. But like I said, it's stress fractures are caused by kind of a number of things. There's relative energy deficiency, but also we see in these populations a really quick spike in activity, both in terms of volume and intensity of impact activity, which we know is potentially correlated with increased stress fracture risk as well. So I think it is multifactorial in nature, for sure.
Yeah, and things that come to mind when I think about this is, and I may just not fully understand the article, but this was just looking at prescription of NSAID and diagnosis of stress fracture. It doesn't really talk about like which preceded the other. So there could be people who are prescribed NSAIDs because they were having leg pain, and then they find out they already had a stress fracture to begin with. So I think that's important to notice as well. This is just, both of these things are happening. We do not have a linear time frame of, said individual was taking NSAIDs for 3 years. 4 years later, they were found to have a stress fracture. So keep that in mind, that there could be that potential for individuals where this was prescribed or utilized individually for pain management from an injury that they already have, and it wasn't one preceding the other. The other thing it doesn't talk about is, this is prescription. It doesn't say anything about utilization, or more importantly, appropriate utilization. You can give somebody a bottle of 40 pills. One person may take 2 pills a day for 20 days. Another person may take them all within 48 hours. Yep. Both are going to have drastically different effects from a metabolic standpoint and just a general well-being. So I think also people who are, when we talk about the nature of a stress fracture, it's an overuse injury. So it's an overuse injury from repetitive stress. There's also going to be a nutritional component to it as well. But individuals who are getting stress fracture, I think of them usually in one of two buckets. They're either people who are going from a very low volume of activity and very low intensity activity, and they rapidly spike to high volume, high intensity. Or you get the people that just never rest, and they're working out all day. They have a labor-intensive job, where like in this population, their military career is something that puts them in a high impact, high volume, especially during basic training and other things like that. But there are also individuals that outside of that, they're going and finding other physical things to do as well. So I think there's a lot to unpack with this one. You had alluded to it earlier. It's really like energy deficiency. So we have people who have high amounts of activity. They do not have the appropriate rest, recovery, nutrition potentially to facilitate this high level of activity. And then all of the other comorbidities that may predispose somebody to developing a stress fracture. So again, one of those studies where you say, hey, this is pretty cool, but let's just be mindful of what we're taking away from this.
Yeah, exactly. And I think even just in the background kind of alluded to that biological plausibility is there, but there's really no human studies that says there is necessarily 100% a correlation or causation in terms of the biology behind it, let alone then when we put those things into real clinical practice and real humans in real scenarios. So this study, I think, just does a good job at kind of retrospectively looking and saying, A, probably the prescription of NSAIDs in this population is pretty high, and B, there appears to be a correlation between individuals who were prescribed NSAIDs and those who then went on to get stress fractures. Now, like you said, it's very frequently multifactorial. There's no idea about physical readiness leading into these situations, about physical and mental health, about energy deficiency, about nutrition, about all of those other things that we kind of know and are confident that do affect it. But it's something at least that we can talk about and I think begin to open the conversation a little bit more. Maybe does the prescription of these NSAIDs potentially lead to or impact the diagnosis of a stress fracture?
Yeah. And I think another like common clinical profile where this would be relevant to me, not even just in your military population, but think about all the individuals, whether they're youth or collegiate or high school or just your active adult, where they're coming in with lower extremity pain. You're struggling to find impairments that have a soft tissue component to them. They describe an activity profile that's highly repetitive, high impact, and they also describe chronic NSAID use. I've been dealing with this pain for about 6 months now, or over a year now. I've been taking NSAIDs off and on for this, and you're their direct access person. They haven't gone to their physician yet. They haven't gotten imaging yet. you're struggling to find range of motion or strength impairments that really correlate to something non-bony in nature, that may be just a combination of factors that say, you know what, we can go through some things today, but I do think it's in your best interest to check in with your physician or check in with an orthopedic. Let's see if they think imaging is warranted and make sure that we can rule out potentially bony involvement here.
Yeah, so, exactly.
Christian, as always, appreciate the time and effort on this. Hopefully anybody listening got some valuable information from this. If you have any further follow-up questions that you'd like to ask, do not hesitate to reach out to myself or Christian. As always, thanks for listening.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.